So we have been looking at a particular way of doing immunotherapy, cell therapy, using CARs or chimeric antigen receptors. The basic approach is that each patient must provide cells for their own treatment. We apherese these patients to collect T cells. The T cells are genetically engineered with a lentiviral vector, which actually is a modified form of the HIV virus, and that puts a gene in the T cells that then allows the cells to produce this CAR protein. The CAR protein targets the T cell to the cancer cell, and it also activates the T cell so the T cell can efficiently kill the cancer cell, and also, we hope, proliferate significantly in the patient. So right now, most of the work in this area has been focused on B-cell cancers because we use the antigen CD19 as a target, and that's a great target. The only other cells, obviously, that express CD19 are normal B cells. We do expect the normal B cells to be destroyed by the cell therapy, and that's fortunately something that we can tolerate because we're able to do antibody replacement in these patients. The issues are really, you need to target, and the CAR does that, and there are lots of folks who've done that. You need to grow enough cells to be able to treat patients, and there are various ways to do that, and they are clinically compliant, what we call GMP. I think the issues have really been what happens